Thank you so much. And I'm so happy to start with the patellofemoral joint, finally. So I will speak about trochlear dysplasia and what is trochlear dysplasia in 2025, because things are changing a little bit and you can see the trochlear dysplasia in a different way, and maybe you can rate it in a different way, and maybe even much more easier than previously. In 1987, my father and Gilles Walsh did a classification in 3 grades looking at the crossing sign. And what they did at that time, they just make the true lateral view reliable and understandable, because they align the 2 condyles and they define the crossing sign. The CT scan at that time was used not for the shape, but was used to measure the TTTG. But they defined 4 risk factors: trochlear dysplasia, patellar alta, excessive TTTG, and patellar tilt over 20 millimeters. And then I came in 1998, and I changed a little bit this classification because the interreliability was really bad for the first one, and we match X-rays and CT scan. We match the shape of the trochlea on the CT scan, and we look at the crossing sign and the spur, the bump at that time, and we come up with a classification in 4 grades, A, B, C, D. Very useful and worldwide used. But a lot of controversies on this classification. And I understand that, because nobody has good X-rays, nobody uses CT scan, and people were mixing everything. Even in UK, they published a new classification, 28 patients in GBGS on the shape of the trochlea, so we'll see. But no evaluation on the trochlear bump. And this is the key for high-grade trochlear dysplasia. So, for sure, everybody is using the classification in the wrong way. So what to do with this is probably to look at the limitation. The limitation was to have good X-rays. Nobody has good X-rays, always like that or like that. Nobody used the packs of their hospital, measuring by itself all the measurements. So could we have better? So I went to Italy and I met Sophia Loren, and Sophia Loren told me, David, look at the patellofemoral joint in a new way and look at it with new eyes. And what are my new eyes? My new eyes would be definitely MRI. And I took some chefs from different parts of the world, all my fellows, and we did a huge work on MRI, looking at the trochlear dysplasia, looking at the sagittal plan, and looking at the axial plan, with control group and objective patellar instability group. And we come up with some interesting things. Because MRI, everybody's coming with an MRI. You can see hemarthrosis or lipohemarthrosis, you can see the cartilage, you can see the bone bruise, you can see the soft tissues. Good. But you can also measure everything with a ruler or with your packs. The goal is to make the difference between a normal trochlea, what is a normal, a flat with no preeminence, A or C from my old classification, and the flat or convex with preeminence, B or D, the high-grade trochlear dysplasia. So we have to look at objective data, and we need to measure things. On the coronal, we have the trochlear groove angle, which is something new. On the axial, you have the shape, concave, flat, convex, very easy. Sulcus angle, lateral trochlear inclination, the CTO and the bump, and the sagittal also the bump. So these are the elements that you should look at. And we did a huge amount of measurement with some different people, 5 people in each group. And what we have seen is that, first of all, if you look at the shape, wow, the ICC is very low. So you cannot rate the trochlear dysplasia using the shape, flat, convex, or concave. That's wrong. Sometimes when you measure the sulcus angle or the lateral trochlear inclination, sometimes you cannot measure it because it's flat or convex. So it means that it is unmeasurable. So this is something that you can rate. You say, I cannot measure it. All the other factors were very reliable. So the first is the trochlear groove angle. And when you have a high-grade trochlear dysplasia, the orientation of your groove is going medial. 12 degrees for the high grade and 4 degrees for the control. So it's very different. This is something that when you do a trochleoplasty, you need to change. And this is one of the goals of the trochleoplasty. This is the values. And of course, more your TGA is high, more the TTTG is high, for sure. The second is a circus angle, very famous, very easy to measure, and the threshold between the control group and the instability group was 157 degrees. And if you go over 157 degrees, you start to be dysplastic. Low-grade trochlear dysplasia, but dysplastic. If you look at the LTI, this is exactly the same, and the threshold that we found was 14 degrees on MRI, using the cartilage. We always use the cartilage when you deal with the MRI. So sometimes you see it's unmeasurable. You see on the left, you cannot measure it, but you say it's unmeasurable. So finally, we look at the CTO, which is pretty tough to measure, I agree. But this is very informative about the way your trochlear is going laterally and push the patella on the lateral side. Definitely, it increases the tilt of the patella, and you see that it's something very important. But how to pick up the bump? And the bump is the biggest pattern for patellar dislocation, and it is definitely the biggest mistake for a surgeon when he missed it, because he will do an MPFL, and the MPFL couldn't work with a high-grade trochlear dysplasia, Laurie. So why could you underestimate it? Because of this bump and the knee rotation, perfect X-rays done in Lyon, France, perfect. Then you have this X-ray done in somewhere in the world, I don't know where, but you cannot look at the trochlear at that time. And if you look at my fluoroscopy, you see more you turn the knee, better, less the trochlear dysplasia is easy to pick up. So when you look at the MRI, you have exactly the same problem. And you face exactly the same problem. If your condyles are aligned, perfect, no problem, you can measure the bump. If not, you will see that if you turn your MRI right or left, internal or external, the trochlear is not understandable. So you need to realign the condyles when you deal with the MRI. And when you do that, you will be back to a good situation to look at your trochlear dysplasia exactly the same way when you change the orientation of your X-rays and you make a perfect true profile. So this is very important. So you have to take from the MRI the 3D acquisition or the native acquisition, and you need to ask your radiologist to give you those files. And then you will be able to measure the bump after using the MPR mode, where you put your two condyles on the same line. And the threshold for high-grade trochlear dysplasia will be 5 millimeters. So here again, this is a very important factor. And then you will never miss this central bump, and you will never miss the old type B or D trochlear dysplasia type. So we move to this V3 MRI classification, which is more easy because it goes from normal to high grade. It's a linear classification, different from the A, B, C, D, from 0 to 3. And from trochleoplasty to no trochleoplasty. And this is what is important, because when you use a classification is okay if it brings something to you for your indication. If it's a classification just for a classification and put your name somewhere, it's definitely not useful at all, except for your ego. So type 0, it's a normal trochlear. And the normal trochlear, you have no bump. The sulcus angle is below 157 degrees, and the LTI is over 14 degrees. The adjuvant factors would be the orientation of your groove. This is the normal trochlear. Then you have the type 1. Type 1 is a low-grade trochlear dysplasia. The bump, no bump. The sulcus angle is measurable, and it's between 157 degrees to 179 degrees, because after it's not possible to measure it. And the orientation is of the groove, and the CTO are those other adjuvant factors, but they are just informative. We don't use them to classify the trochlear. Then the type 2 is a moderate grade. The bump is less than 5 millimeter. The sulcus angle is not measurable. The LTI is not measurable also. So it is different from the type 1 because of the flatness of your trochlea. But I will not use flatness. And the type 3, this is the high grade, where you have this bump and the proeminence of your trochlea, which push the patella on the lateral side. You have a bump over 5 millimeter. You have a sulcus angle over 157 degrees or unmeasurable, LTI less than 14 degrees or unmeasurable. And this is what we call the high-grade trochlear dysplasia. And why this classification is important? Because you identify this big love, the bump. So we move to this classification, and you can have it on a CASA journal for free. So why it's interesting to look at this trochlear in that way? If you look at the type 0, 1, or 2, there is no need for a trochlear procedure because there is no bump. The type 0 and 1, there is a sort of congruency. So if you have a congruency, MPFL is okay, TTO maybe, but definitely nothing to do with this. If you look at the type 2, there is no congruency because it's almost flat. And if it's almost flat, the MPFL maybe work, but maybe it would be not sufficient. And maybe you should consider engaging the patella a little bit more in the trochlea by making a distalization of your tibial tuberosity of 5 millimeter maybe, just to engage the patella. And then if you move to the type 3, wow, high-grade trochlear dysplasia, you see I remove the bump. You see that the bump is a big bump. Huh? And if you leave that, it's exactly the same as if you do a total knee arthroplasty with this horrible overhanging of your femoral component. So you have to do something in those things. So definitely there is somewhere an algorithm to do and to treat your patient. So don't forget, one tool always available, this is the MRI. You have to standardize it and use the 3D acquisition with the MPR mode. Align the condyles, measure the bump, the sulcus angle, the petal height, the sagittal petal engagement, and correlate them to the procedures available. This is the best menu à la carte, or the algorithm, but I will not speak about that, of course. But just highlight the fact that for the trochlea, you may do a trochleoplasty, but you may also do a TTO just to engage your patella in your trochlea more distally. And you will be so happy, and your patient will be very so happy. Thank you so much.